Welcome to the Doug's Nyquist podcast, where interested is interesting. And today I am interested in chatting with Dr. Max Gulhane. He's the host of the Regenerative Health podcast and a family practice doc in Australia. Is that right? And
Tony,
he's also gone down the circadian biology train and, diet nutrition train and all sorts of things that we as clinicians don't usually get much education on. And so I guess the first question up is how did you decide to become a doctor, Max?
it was a family thing that I critically asked myself if I wanted to participate in and didn't have enough reasons not to. So eventually did scientific science degree, bachelor's undergrad, and then thought I'd give this a go and found my way into medical school after doing 4 years of science and bedside, a year of benchside research. And I did medical studies and came out or towards the middle and throughout the degree, I had my own health issue. And so I had a kind of medical background and a lens with which to try and understand the problem that I was dealing with, which was, acne, which on the scale of chronic diseases is the most mild, perhaps, of all chronic diseases. But it was at least my introduction into this concept of an exposure to this idea of how modern and mainstream medicine deals with lifestyle conditions, which is a after diagnosis is some very little, depending on who you see, advice about lifestyle, and a complete lack of acknowledgement of the role that plays in the development of the condition, and then an escalating ladder of pharmaceutical intervention, and where you end up as a patient on that ladder just depends if the earlier drugs were successful often in dealing with that condition. And if they're not, then either you get a higher dose or you get another agent added. And this kind of template exists for acne. It exists for high blood pressure. It exists for diabetes. It exists for Parkinson's disease. Exists for any form of autoimmune disease. And so all these conditions of modernity, these chronic diseases, these which have their genesis in lifestyle, are essentially being medicated um, along some form of this template. Dr. Jack Cruz, who we've both interviewed, he calls this the sausage grinder of centralized medicine, which is it in many ways it is. And the thing that struck me about this process, and luckily I had my own personal insight into this process, otherwise I might have become a anesthetist or anesthesiologist or something else, was the realization that if it's me with acne, then what else are people suffering from, and preventably suffering from for potentially decades, unnecessarily, because they haven't been informed of effective lifestyle treatments. And I managed to solve my problem initially with low carb diet, and then following a carnivore diet, and then obviously maintaining with the circadian biological principles of maintaining a strict circadian rhythm by getting full spectrum sunlight exposure, by eating locally, and by maximizing grounding. All these very simple free interventions, again, that we don't get talked about. But my journey throughout my medical career, I guess, was irreversibly altered by this personal experience, because I realized that I could offer other people some help by exploring this area and applying those principles that helped cure me to this titanic problem of chronic disease and metabolic disease. And metabolic disease, the metabolic syndrome, of which type 2 diabetes and ischemic heart disease and stroke and Alzheimer's, dementia, and other neurodegenerative diseases and aging are the kind of end product. And these are the kind of the biggest problems in society, which can be reversed, prevented, and obviously prevented with optimal lifestyle. So, went through medical school, got into worked as a general doctor throughout emergency departments and general medical wards, and then started family medicine training, which is what I'm kind of progressing through at the moment, and really finding value in exploring these topics that don't exist in the medical curriculum and communicating them through mediums like my podcast
Mhm.
and like YouTube. So it's been interesting and fun and rewarding, and I think it's it's been, yeah, all of that, and particularly in, I guess, uncovering what exists as a quite a giant body of research, particularly around light and circadian rhythms. So it's all there, but it's just simply not being communicated in the way that people need it to, and that's, I guess, the fun of doing what I'm doing at the moment.
Mhm. So you mentioned metabolic health, and I think like especially like on, social media health and things like that, I think there's a strong attention or direction that people are understanding what metabolic health is. I mean, you see like certain, internet doctors like, espousing CGMs, and like I think Dr. Tro is like $50 CGMs, I think, to his patients, online. So it seems like metabolic health is gaining some traction. Um, but like once you talk to Dr. Jack and then you start understanding like the circadian biology of and the circadian rhythm, it seems like that's where we have some work to do to get that message out, because it doesn't seem people seem to be latching on to the, no carbs and, processed foods, but no one's really understanding like the light story, right? Would you agree with that or no?
Yeah, definitely. And what I believe is that optimal metabolic health is a downstream consequence of optimal circadian biology and optimal environmental inputs. And I'll explain what I mean by that. So you're correct, and I agree with the diagnosis, which is that more and more people are realizing that metabolic health is something that is desirable. And so the to back up slightly for the listeners, that the metabolic syndrome is this constellation of features that was identified in, I believe, in the late 80s, uh, as as a risk factor for getting those end stage chronic diseases that no one wants, that everyone had, that more and more people are getting. And those risk factors so are high blood glucose levels, high triglyceride levels, low high density lipoprotein or HDL levels, raised waist circumference, and high blood pressure. So those are five features. And if you have three or five of them, then you score yourself a diagnosis of metabolic syndrome. What they were is, this was before we had the ability to measure insulin effectively directly. Nowadays, we can simply draw off a fasting insulin level. And really, if it's above five, 4 or 5, uh, to really give a strict reference range, then you basically diagnose someone as having insulin resistance. And those are those that, let's say, so I've given you a sixth with the fasting insulin. That's a sixth marker, but really there's even more than that. There's things like a plasma urate level, which is obviously elevated in conditions like gout. There is liver function derangement, like ALT, which is a marker of, can be a biochemical marker of hepatosteatosis or fatty liver. And then there's other markers like, glycated hemoglobin, which are obviously a more direct measurement of metabolic dysfunction. And then so these are all simply what one of my mentors called windows into the same room. These are just different windows into the same room of metabolic disease. And obviously visceral fat is also a massive part of that, which is essentially body storing fat in the wrong places. But so metabolic syndrome, metabolic disease is the problem because it puts you on the train track to developing diabetes, developing dementia, etc. So the question is now, and with your reference to, the internet, other doctors and what people are talking about, like Dr. Callie Means and her brother Casey Means, and sorry,
Kelly.
Dr. Casey and her brother Callie, is that the food is the kind of the main talked about solution to this problem. And I agree that it's a major part of the problem, but it's not the only part of the problem. And the reason why it isn't is because fundamentally at its core, metabolic dysfunction is mitochondrial inefficiency. And it is a inability or a reduction in the effectiveness of mitochondria in their role as these tiny little batteries, power plants that essentially transform energy, whether that's food energy or light energy, into usable energy by the body. So, when you metabolic dysfunction, essentially that is what is happening, and there's all you know within that we can go into the minutiae of exactly what's happening, but on a high level, from a high level point of view, it's a mitochondrial issue. So the question then is, how do you optimize mitochondrial function? And in their book Good Energy, they're talking about optimizing the mitochondrial energy through avoiding processed foods, through avoiding toxins, endocrine disruptors. Yes, that's all relevant, and that is why a low carb and ketogenic diet is so effective in preventing and reversing metabolic syndrome. But fundamentally, the mitochondrion is an environmental sensor, and it relies on optimal light and temperature inputs to work optimally. So, yes, you can fix a broken engine by putting a cleaner fuel in it, but you also need to consider it's the lubrication and the coolant of the engine, so to speak, and that those are analogies for the light environment that exists in, and things like melatonin, which essentially again get made but on exposure to near infrared light, but also the temperature system. So, what I think is that when someone gets the circadian signals right, they rise and fall with the sun, they avoid exposure to artificial light at night, and they get a skin type latitude appropriate amount of sunlight, and they expose themselves to the ambient temperatures of where they live, then it becomes extremely difficult to develop metabolic syndrome because your mitochondria are not functioning properly. And the crux, I guess, of Dr. Jack Kruse's message versus what he calls the food gurus is that once you live this circadian lifestyle, you actually have latitude to consume less optimal food without manifesting disease because the more critical inputs of light and temperature have been taken care of. Now, I agree with him. I still don't think that we should throw, our food choices into the wind, and I think it's still an important part of the puzzle. But I do agree that if we're only concentrating on food, we're really missing what are the more important or the most important factors that affect longevity and mitochondrial health, which are those light and temperature signals that I mentioned.
Yeah, so I think part of it though is the fact that we just can't, I mean, the modern society doesn't allow us to actually live a circadian lifestyle easily, right? It takes significant work to, I just finished work and I'm sitting in my office with a red light on me, so I couldn't even get outside. So, I mean, most people are in the same boat, right? So how do you handle that with your clients or yourself? Like when you like, because I think that's the discussion of when food becomes, important, because if you have to make choices, then you have to, carbohydrates work well with a strong light source. And so if you're not getting a strong UV source in the wintertime, then that could be a problem, right?
Exactly. So the food becomes relatively more important if we're unable to live to get the light signals correct or appropriate ideal as we'd like. So it it essentially becomes a situation where people are living indoors. They are essentially simulating a low UV environment, both by depriving themselves uh of natural sunlight, but also being indoors and being um under this isolated blue, alien light. So people are simulating this low UV environment and while consuming kind of almost many times a processed food diet, which is completely removed from photosynthesis and the appropriate light signals. So yeah, it's very difficult. It's difficult, but the emphasis on the light is because that is the root cause fix from, say, someone like Dr. Cruz. So I guess his, to just comment briefly on his approach, would be, it's always, in as a clinician, you always have to tell the patient what you believe is the best thing for them. It's up to them whether they decide to, take that advice, or whether they decide to go with, suboptimal compromise kind of lifestyle steps. But it always, is incumbent upon us to really tell people what we believe is the most root cause fix to their problem. So, yes, if we can't do anything about our light environment, then most people will benefit from a low carb diet. I think that's unavoidably. I think that's correct. And only when we're getting heaps of natural light and UV light that we can eat as many carbohydrates as, say, Dr. Paul Saladino, living on the equator, or equatorially ninth, 10th
Latitude.
latitude in Costa Rica. So what do I do is, I just encourage people to do as much as they can. Like that is all that you can do, is get shades of optimal, which is as much as your lifestyle or permits, and just and keep learning and understanding what lifestyle choices you're making that are trading off against what is optimal.
And one of the things I appreciate, I mean, Dr. Jack kind of hit you pretty hard, like on the food topic on your podcast, and you've gone down the rabbit hole, and you've had guests on your podcast that are trying to actually do the science on this and actually find out the science. So, I mean, tell me about your discovery into and fact checking Dr. Jack, because I think that's what he's asking us all to do, is to fact check him. And so I think that's an interesting it's an interesting sidebar of watching your journey of the last year or so.
Yeah, it has been very interesting, and the fascinating thing is that Dr. Cruz makes a whole bunch of statements, and on the surface can seem quite outlandish, but you go through this process of verification, and you almost invariably find that he's correct in everything that he's saying, which is, it's good. It's a good thing to be able to double check that and verify. So yeah, to elaborate on my journey was, and the podcast when I started was very much food focused, and talking about carnivore and low carb and seed oils as the kind of foundation of a preventative health strategy, which and again, I'm still going to say that they're part of the picture. But after talking to Dr. Cruz and essentially being invited intellectually to step up and step into, I would frame it differently, actually, to dive into deep water. That is essentially the invitation that he gives you, and which is to go beyond what your intellectual thought paradigm, and experience the discomfort of being a intellectual beginner again, and then work through these claims to verify them, with the interest and the goal being is to get closer to truth, and therefore be able to help people more effectively. And that's what I've been doing since I talked to him, and I think I've released maybe 40 podcasts since I talked to him. And yeah, I've spoken to optics engineers who've pivoted to looking at the light interactions with the body. I've talked to neuroscientists who are using red light and the effect that it has on mitochondria. I've spoken to an astrophysicist who's now looking at infrared light and life interactions. Who else? I mean, I've spoken to dermatologists who are doing systemic research on the systemic effects of sunlight on health. And there's been a lot of different ways to interrogate these ideas and to explore this this picture, and which is both circadian biology and quantum biology. And to be fair, my focus has mostly been on circadian biology. And for the listeners, that is the exploration of particularly this 24-hour endogenous clock in our bodies, and how our bodies have adapted to different light signals. That is distinct from quantum biology, which is the study of essentially how quantum mechanical processes exist and affect in biological systems. So that the terms get thrown around quite, almost interchangeably, but they are very distinct, although interrelated in their definitions. And to quickly make the point, because we were talking about metabolic syndrome, is that circadian biology and quantum biology are fundamentally involved in diabetes and metabolic syndrome. Circadian biology, because all the metabolic organs in the body, from the pancreas to the liver to the adipose tissue to the muscle, they, and obviously the brain itself, are running on circadian clocks, and their processes, metabolic processes, and like fat burning, glycolysis, glycogenolysis, insulin sensitivity, um, glucose levels. These all run on circadian timing mechanisms, and that shouldn't be surprising to anyone when we understand what the purpose of the circadian mechanism is, which is to optimize energy flow and to make the organism as energy efficient as possible. And it's not energy efficient to be pooping, at all times of the 24-hour cycle. There's a reason why, from a circadian point of view, the gut peristalsis happens soon after seeing the morning sunrise, and that's the time that people take a bowel action. So all the processes that are required for you to have optimal circadian health are dictated to and influenced by circadian rhythms and optimal circadian signaling. So that's how I think about light and circadian rhythms as it applies to metabolic health. And then on the quantum level, it appears like the interactions of light photons, particularly in the near infrared, are critical for mitochondrial health. And those red and those near infrared photons, they're helping essentially the spin dynamics of the fifth complex in the electron transport chain. And if you put someone in a near infrared and red deficient environment, they're going to lose mitochondrial efficiency, and they are going to become pre-diabetic and diabetic. So that's just a really brief insight, I guess, onto how I think about light as it specifically relates to metabolic disease. But the journey that I guess I'm on with the podcast that you mentioned earlier is really one of helping to educate people that there is this massive part of health optimization and metabolic disease prevention that has got nothing to do with food, and has got a lot to do with being in the correct light environment for our biology and for our genetic heritage.
Yeah, because I actually met Max a few years ago. I was digging into visceral fat because as a dentist we can optimize skeletons, right? So we can fix jaws, we can do double jaw surgery, we can recommend these things. And so I had a couple incidents where patients, we optimized skeletons, and sleep improved marginally. There was only certain things. So my first initial thought was that maybe this is a visceral fat situation, that maybe they're actually gaining, it makes skeleton bigger and they just gain more visceral fat in their airway passages. But once you actually start thinking about the circadian biology and you start thinking about metabolic disorders, you start thinking about red light in the daytime, blue light at night. It really does seem to marry themselves together. And how as a dentist, if we're going to be discussing these things for optimizing skeletons, we should also be optimizing circadian biology and metabolic health at the same, because they both kind of tie in together. I don't think you can sleep well if your metabolic health is poor or your circadian biology is poor.
Yeah, exactly. And that's it's a good point to reference Dr. Sean O'Mara, who we both, I think that's how we
Mhm.
initially connected.
Right.
And his work has been very, very important and very, very pivotal. And he specifically talks about the deposition of visceral fat and the identification of it using modalities like MRI scanning to kind of look at the problem, well before uh, the disease is manifested. So Dr. O'Mara has these five causes of visceral fat deposition, which I really like, and I talk about, but in slightly different terms. So he talks about processed foods, including carbohydrates and fruit, uh, poor sleep. He talks about stress, chronic stress, alcohol, and chronic cardio as five causes of visceral fat deposition. So when I talk about it, I talk about the same, but I talk about it in a more nuanced way. So, what instead of poor sleep, I talk about circadian disruption because I think that is attendant within poor sleep is simply is going along with circadian disruption as a cause of visceral fat deposition. And we have data. We've got data from human data, epidemiological data with hundreds of thousands of people showing that light at night is related to hypertension, obesity, diabetes. So we know that light at night for humans is causing this visceral fat deposition, and we've got mouse studies too showing the exact same thing with shift work. So
So
that's how.
people are literally there's data that shows that people are literally getting obese just from their light sources, not from their diet necessarily.
Yeah, exactly. And I had an interesting conversation with Kelsey Dexter, who's an endocrinologist in Tennessee, I believe. And she made the point that, compared to 10 years ago, compared to now, there was processed food 10 to 15 years ago. And it doesn't appear to be that the access or consumption of that, I mean, it's just as high as it has been. Yet kids are even more obese. There's more fatty liver in pediatric populations, and you probably it's the iPad and the blue light exposure, in addition to the Slurpee and the and the processed food, that I think is particularly problematic. But to come back to the causes of visceral fat, so I think circadian disruption is there. Processed foods, obviously, carbohydrates and fruit, but only if that is eaten out of is not congruent with the light environment that we're existing in. And obviously processed foods include the carbs, refined sugar, and the seed oils. And chronic stress, undoubtedly. I mean, this is one that is so ubiquitous and so important. Alcohol, obviously, and chronic cardio is not one that I have to talk a lot about with my patients who have metabolic syndrome and visceral fat. But
Not
Dr. Amara, who deals with more corporate high flyers who've maybe they're in some running group because that's the thing to do on a Saturday morning after you've done
Mhm.
your merger and acquisition. Then they run and they end up having difficulty getting rid of their visceral fat. So all that to say, I really strongly agree with the essence of what Dr. Amara is talking about. However, my emphasis is more on the circadian disruption and the light part of that visceral fat deposition story.
Yeah, it's almost like a cause or an effect because of the poor circadian biology, so to speak, right?
Yes, exactly, like a biomarker, and that's what Dr. Jack said in in his podcast with me, is like visceral fat is the marker of having a low redox. It's the marker of living this ancestrally inappropriate lifestyle, and it's I guess it can be seen as the body compensating in a way. It's a um for these suboptimal environmental inputs.
Yeah. So, you hear all these terms like you hear like redox versus detox, and so what is your definition of redox?
Yeah, it's one that does get thrown around here and there. And look, cellular redox, I mean, fundamentally refers to these. essentially the passage of electrons around and the changes in states of these key proteins in the electron transport chain that are involved in metabolism. So uh, the idea, I think, at its core is having sufficient electrons, having um, abundant electrons with which to perform the metabolic functions of the mitochondria and electron transport without generating excessive reactive oxygen species, and therefore, having optimal mitochondrial health. So that at a high level is what I how I think about it, and it necessitates and it implies things like sunlight, grounding, because those are how humans assimilate or incorporate and generate massive amounts of free electrons to run these processes in the body.
So yeah, it's an interesting I remember my biochemistry from like, 30 years ago, and it's a whole new study to try to learn like what the mitochondria actually do and like where they come from. And it's kind of like when you don't really realize that you don't actually need the food, you can actually get the electrons from the ground and from the sun. I mean, that's pretty much the crux of the story. Food helps, but we need it eventually, but we really don't, it's not really a, necessary, you know, source of electrons, right?
Well, the it's true, and if you look at the biology of this pro hormone, this polypeptide pro hormone called pro-opiomelanocortin, and you look at the different functions of uh of the cell, but also of the mitochondria, and then you start to see that the body has evolved processes that actually turn off uh, food satiety in response to strong ultraviolet light. And that is one of the effects of one of the POMC cleavage products, alpha MSH, when in the brain, in the hypothalamus, it is a very potent satiety signal that stops us from eating. And that means the translation for the listener is that when you're in strong UV light and your body is deriving energy from that, and thus it's turning off your desire to consume uh, electrons from food.
Yeah, it's a wild thing to think about. I mean, it's like, it's one of the most exciting things that I've learned over the last year is that like, how important the sun is. And I think the sun's actually demonized quite extensively. We're trying to block it, it seems. We're trying to like um stop melanoma and stop skin cancer and stop all these things. And at some level, you actually have to start thinking, is that the right approach, right?
Well, let's take it a step further. If we understand that UV light has this profound effect on satiety to stop people eating, then you can think of it as an anti-obesity drug. And
Right.
lots of the medications that in private in practice that we use for obesity rely on reducing satiety. That is what the GLP-1 agonist injectable medications like semaglutide, which is Ozempic, that's what they do. They reduce satiety. And so if we can get that for free without the attendant side effects and adverse effects from the sun, well, that suddenly becomes a unpalatable competition for industry that are making bucket loads of money.
Right.
So it's not only like the evidence for the benefit of UV light on weight is and metabolic health is large and growing. And there was a study done in mice, and they again, it's limited in its applicability, but it's telling as well, which is they exposed one group of mice to narrowband UV light and one to a control, and they fed them the same diet, and the UV light exposure conferred extremely powerful obesity resistance. They just simply didn't get obese. So if you pair what we're seeing from a chronic disease and health point of view today, which is that obesity is continues to rise, and attendant metabolic syndrome is rising, at the same time as we are being told to stay indoors, and that less and less people are getting full spectrum sunlight. then that appears it's quite obviously a perfect storm for exacerbating metabolic syndrome and and obesity. So what there was a saying that you shouldn't attribute to malice what can be attributed to ignorance or stupidity, but there is enough data in the literature to show that the anti-chronic disease effects of full spectrum sun exposure that you really, I think an inquiring mind needs to ask the question is whether there is some intent in sun demonization compared to or linked to the promotion of the pharmaceutical drugs. Because and maybe if you don't mind, Doug, we'll
Yep.
quickly go through them,
Sure.
because I just mentioned GLP-1 agonists. Let's consider each of them in the context of their effect on physiology and the corresponding sunlight effect. So GLP-1 agonists reduce satiety, and therefore people lose a whole bunch of weight. They lose lean mass and they lose adipose tissue because they're simply they don't eat as much. What else do we know about the effects of sunlight? So it reduces total cholesterol and LDL cholesterol and triglycerides. And we know that from a couple of studies. Some of them are observational, which is that, and this is very highly replicated, which is that serum lipids exhibit a seasonal dynamic, and they have their nadir over at peak summer, where the ultraviolet light, this is particularly in Europe that I'm referring to, that with a peak of the ultraviolet light shows people's serum lipids are the lowest. So this is what Pelly Lindquist, who was the chief investigator of probably the most pivotal sunlight and all-cause mortality paper called the melanoma in southern Sweden cohort. He said that recently to Cameron Borg, which is sunlight reduces cholesterol. Sunlight reduces and what else is it doing? It's a cholesterol, which is the main component inside the low density lipoprotein particle, is used as a precursor for the production of vitamin D. So if you are constantly being irradiated by UVB light and your body is constantly producing a vitamin D, then you are sucking cholesterol. The cholesterol is coming from somewhere, and it's going to be drawn out of the circulation and from lipoproteins to synthesize vitamin D. So what also reduces vitamin D that most people are on these days? Well, that's the statin class of medications, which are the HMG CoA reductase inhibitor class of medication. So we are pharmacologically lowering cholesterol, total cholesterol, LDL cholesterol. And when the sun does that, full spectrum sunlight will do that. So what else can the sunlight do? So blood pressure. High blood pressure is, in terms of the cardiovascular risk factors, it's up there next to smoking as one of the most important risk factors for developing stroke and cardiovascular disease. So people are on a range of medications, from diuretics, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers. These are all medications that pharmacologically lower blood pressure. What happens if you get into full spectrum sunlight? Ultraviolet A, ultraviolet B, and blue visible all have a vasodilating effect on the circulation. So Professor Richard Weller was the first one amongst the first to delineate this mechanism, and he specifically used UVA to demonstrate that this was happening independent of vitamin D system. But what he showed is that the UVA light essentially liberates stores of this very, very powerful vasodilator called nitric oxide from stores in the skin, and that dilates the blood vessels. What we found out later is that both UVB can do that, and actually visible blue, which is right next to UVA on the electromagnetic spectrum. If anyone who's listening goes out into the sunlight and has been there for 10 minutes in reasonably strong sunlight, you will notice the prominence of the vasculature on your upper arm. This is in people who are reasonably lean. Mm-hmm. What that is showing is that how the blood vessels are dilating and blood flow is increasing in response to direct response to sunlight. So, what and this is occurs or is attendant with reductions in blood pressure. So, not only is full spectrum sunlight lowering cholesterol, which is a cardiovascular risk factor, it's also lowering
Pressure.
it's also lowering blood pressure. And again, it's replacing, or it's the medications are medicating a sunlight deficiency.
Hmm.
That's how it can be thought of. And if you're interested, maybe we could talk about, or we don't necessarily need to, but this idea that the red blood cells, they have a spectrum of absorption spectrum that is in the visible range, but that's aiding in oxygen delivery. So the whole purpose of them, and Dr. Cruz has mentioned this, is that blood is this fluid that is acting like as an antenna that's connecting the sunlight to us as on planet Earth. So there's a foundational reason why sunlight dilates blood pressure, and I would assume that it's to irradiate as much as the blood volume as possible with natural radiation to aid in perfusion, blood flow, and oxygenation. But what else? What else is there? So we've talked about blood pressure. We've talked about
Cholesterol.
cholesterol. We can also talk about blood glucose. So blood glucose levels are influenced by light, and that we found that out recently by Glenn Jeffries' work, who's a expert researcher, neuroscientist at UCL, University College London, and his landmark RCT, randomized control trial, which was so simple and cost, I imagine, would have cost next to nothing, simply compared two groups of people, one that had a red light exposure for 15 minutes on their back, 670 nanometer LED light. Yes, it's not full spectrum sunlight, but it's 670 nanometer is a significant part of natural sunlight.
Mm.
And they gave them an oral glucose tolerance test, which is 75 grams of oral glucose, and then measured the shape of their serum glucose response. And then they measured the amount of carbon dioxide that they're expiring. What they found was that compared to this placebo group, who didn't get the 7 nanometer light, those that did get the light had a significantly lower, 27% lower blood glucose levels in response to this glucose challenge, and they blew off more carbon dioxide. So those of you who are listening who followed the mitochondrial story would know that the exhaust of the mitochondrion is carbon dioxide and water. So we make deuterium depleted water at the fourth complex, and we also make carbon dioxide. So by measuring a higher expired carbon dioxide in the samples of these people treated with red light, they found that they inferred correctly that the reason why the blood glucose was dropping was because the mitochondria were taking it out of the circulation more readily.
Mm.
It was upregulating mitochondrial function. So that's blood glucose as well. That's going to be lowered by full spectrum sunlight, and that ties into the circadian rhythm story, because if we're eating during the day and we're having complete darkness at night and we're not eating before bed, then insulin sensitivity is optimized, glucose homeostasis is optimized. So you're not going to become hypoglycemic if you're in full spectrum sunlight and eating appropriately based on your circadian signals. So those are three of the key metabolic syndrome criteria. Well, four if you include triglycerides.
Right.
And obviously waist circumference is going to come down when
Right.
we're metabolically healthy. So that demonstrates that the metabolic syndrome that we're medicating people for is essentially a sunlight deficiency.
It seems so simple and yet it's so complicated, It's like it's a little bit of a hard one for people to understand. I mean, even for me, it's like, wow, I can't believe that sunlight does all of this. I mean,
And sorry, Doug,
go
to
ahead.
round that thought off. So, I've just given you all mechanistic data, and the devil's advocate in the audience will say, okay, but how does that actually relate to, all-cause mortality? And
Hmm.
that's when I would reference Pelly's study. And that was 25,000 Swedish women over more than 20 years. interviewed at baseline about their sun exposure habits. Do you sunbathe in summer? Do you sunbathe in winter? Do you travel overseas to sunbathe? And do you use tanning beds? And what they expected, because there was lots of melanoma going on, is that
Mhm.
the women who had the greatest sun-seeking behavior would live less. They'd get more melanoma and they'd live less. So what Pelly found was actually that these women who got the most sun exposure lived the longest.
Mm. Okay.
And there was a biological gradient in the effect, meaning that the women who answered yes to all four questions lived the longest. Those that answered yes to two or three of the questions lived the intermediate amount of time, and those that answered no to all the questions died the most more commonly, more
Mm.
often. And what they found on reanalysis in 2016 paper that they published was that that effect was equal in size to smoking,
Mm.
meaning that avoidance of sunlight exposure was was put you in the same risk of death as if you smoked cigarettes.
Wow.
So, what they attributed to this was cardiovascular disease. So more heart attacks, more strokes, and more blood clots. And that is what happens if we stay out of the sun. So, that was later, that finding of all cause mortality benefit was later replicated in the UK Biobank cohort by Richard Weller and his colleagues, Chris Dibbins, I think, which was published this year. And again, it's an observational cohort, but it showed the same thing, which is that the more UV light you get, the longer you live, the less cardiovascular disease, the less internal cancers you get. And maybe you want to talk about skin cancer, but the trade-off that I see is that yes, you might increase your risk of skin cancer if you go out in the sun more, but you're going to live longer because you die less of the real big killers in society, which are predominantly cardiovascular disease, stroke,
Cancer.
yeah, and
Yeah.
internal cancers.
Right. So yeah, so yeah, it's yeah, it's wild. I mean, so that actually correlates to vitamin D as well, right? Because there's lots of data that shows, higher endogenous vitamin D levels and less all-cause mortality, correct? So there, there's
100%.
there's those are kind of related. Those studies are kind of like they kind of mirror each other, right?
Exactly, and that's what I've often brought up, which is how are we so confident that this is a causal relationship? And in medicine and epidemiology, we are obsessed with causation,
Mhm.
and by looking and having trials that show vitamin D deficiency is a risk factor for all cause death is another way of insight into the same finding. And obviously, vitamin D is generated from exposure to 312 nanometer light, well, 290 to 315 nanometer light.
Right.
And vitamin D is a marker of how much sunlight people get. So if you're persistently low on vitamin D, then you're sunlight deprived. So yes, that's a great point that you brought up, because it further reinforces the point that this is a causal relationship: sun avoidance and risk of death, sunlight maximization and longevity. This is a causal relationship.
So talk about like supplementation of vitamin D, because that's a big topic now too. It's like, it's like people like, well, I'm going to take my 10,000 units of vitamin D and that should be enough, right?
Yeah, the supplementation story is very old. It started with the prevention of rickets back in the 1800s, and the finding that cod liver oil was highly effective in essentially preventing these bone complications and of vitamin D deficiency. But it really has been championed by Professor Michael Hollick, who's a endocrinologist and researcher and world expert in Boston. And he's done heaps of very interesting research that support the critical role of vitamin D in human health. The I guess the and particularly one study that he referenced, that he didn't do but he references, that was autopsies of I think it was in a German cohort. They took people who died of car crashes, and they basically looked at their serum vitamin D level, and they looked at bone biopsy evidence of osteomalacia or osteopenia, and they came to the conclusion that above a level of, I believe it was 75 nanomoles per liter of vitamin D, and that there's th- beyond below that, then you could potentially getting complications, whether they're bone or otherwise.
And there
So
is a difference. There is the nanomoles, which is the European and Australian version. I think then the American version is what is it? It's
nanograms per deciliter.
nanograms. Yeah, right.
Yeah, it's I think it's a factor of 2.4, 2.5 or something
Yeah,
to,
something like
to
that.
go to go between that.
I'll look it up.
Yeah,
Keep
so
going.
the point being that we realized, and then subsequent to that, all this research was done showing the association of vitamin D with non-bone related conditions. So initially, we in the discovery of vitamin D, it was a sunlight derived fat soluble essentially hormone that helped us absorb calcium from the gut and therefore prevent uh, rickets, but vitamin D related rickets, osteomalacia, osteoporosis. But it later turned out that this was a key factor in immune system function, and it had not only immune system function, but all these bodily processes. And there was more than, I believe, 3,000 genes have a vitamin D binding receptivity, because it goes into the nucleus and affects transcription of genes when it's finally activated. So the vitamin D story became quite big, and it was a recognition of how important it was. So, Professor Holick has really championed supplementation. But I suppose, and I agree that it's important to supplement if there's no chance of getting optimal sunlight exposure, then getting that level at least to 75 nanomoles should be a goal, and whether you do that by supplementation or otherwise. But
Which is
ideally
pretty
with
much
sunlight.
30 nanograms per milliliter is about what
Yeah,
that would be, right?
yeah,
On
yeah.
the other scale. Yeah.
Yes. Just over
So, yeah.
two times. So but look, to, to answer your question, people have, I think, given themselves a false sense of security that by simply taking this pill that they're somehow, going to uh get the same benefit. And there is studies showing that this is, even in people who are sick, who are having various cancers, that high dose supplementation can have a benefit. That and I don't want to talk about that population. That's not what I'm talking to at the moment. I'm
Mhm.
talking about general
Healthy.
health,
Right.
healthy people and longevity strategy, that we should be aiming to get this vitamin D level from the sun. And the reason why that this is relevant is because, as I mentioned earlier, the vitamin D is a biomarker of sunlight exposure, and you're generating so many other useful, important compounds from full spectrum sunlight that you're not getting if you just take a pill. Of those, there are some vitamin D metabolites there that are, variously hydroxylated, lumisterol, techisterol, and different cholesterol steps of metabolism. They're probably having a role in immune function, immunomodulation, reduction of cell uh, replication, but also those near infrared light effects like melatonin in the mitochondria, like all the nitric oxide compounds, nitric oxide effects. So, there's so many things going on here that if you believe that you're getting the same benefit as the observational data shows of having a vitamin D level of 125 by taking the pill, that is absolutely not the same thing as someone who has a vitamin D level of 125 because they live an outdoor lifestyle and they don't avoid sun exposure.
Hmm. Yeah, because I think I mean the fascinating, you mentioned the mitochondria and melatonin, and I mean 90, what is it, 95% of all the melatonin produced is produced by near infrared light or infrared light in the mitochondria, like throughout the day. So I mean, and then the last 5% is in darkness at night through the pineal gland. Is that correct? Do I have that right?
Uh, so 95% is extra pineal, 5% is pineal, and of the extra pineal melatonin, it's I don't know the exact proportions, but some is gut derived, and a lot of it is from light. That I would really like to see more data on that. There's a couple papers, obviously Russell Ryder and Scott Zimmerman have done that. It would be good to see that replicated and a bit more, elaborated further.
Hmm.
It and it also kind of other reason I don't really like that metric too much is because it kind of almost implies that the circadian melatonin isn't important, but it absolutely is important. So, but the takeaway message is that you can make melatonin during the day, and really to think of that as the engine coolant for your mitochondria that you really need, that you're not getting if you live indoors under fluorescent
Right.
lights all day.
Right. Yeah, because I think it's potential that it's used up during the day, and it's not even there for sleep at night. I mean, that's kind of how one way that I kind of think about it. I don't think it's actually being stored up in this in a bank so that you can have it ready to be used at night. I mean, I think
Correct.
it may be. I don't know. I don't think we know. I mean,
No,
we do, but
but from my understanding is that, as you say exactly, Doug, is that it's being produced and consumed locally to deal with reactive oxygen species,
hmm,
that are generated as part of normal cellular function during the day. So, and you can imagine that when we're talking about things like skin cancer and sunlight, is that how important the time of day is when red and infrared light is enriched, which
hmm,
is it's always present, but it's particularly enriched in the beginning and the end of the day, and how sun exposure habits that involve that exposure are going to be putting people in a stronger stead to prevent skin malignancy
hmm,
compared to those who with a really pale Fitzpatrick skin type, like my countrymen here in Australia, going into the middle of a UV index of 11, in the middle day without any early morning red and infrared, plastered in UV blocking sunscreen, um, and then going out there completely and perhaps maybe even having a disrupted circadian rhythm after that. So I think that it's going to the melatonin being generated in the skin, in the mitochondria of the probably of the keratinocytes and the melanocytes,
hmm.
is a key part of skin cancer prevention that isn't being talked about at all.
Yeah, and isn't the key to kicking off alpha MSH, so like early morning red light and then UVA light, getting that going too? So we can't even build melanin if we don't get the as well as efficiently, right?
Yes.
Is that the
Yeah.
pathway too?
Yeah. There's multiple pathways, there is that are involved, and again, I wish there was more researchers kind of actively researching this. There's possibly the role of a compound called filigrein, but yeah, to keep it simple for the listeners, it's like Mother Nature gave you the exact right recipe to thrive, but you have to live by her rules, and you
Mhm.
have to live in an ancestrally appropriate way that is commensurate with your physiology, and getting the morning sunrise in and not exposing yourself to artificial light is key, and exposing yourself to the correct amount of UV for your skin type is also important, although uh, from what I'm hearing, it sounds like you're still better off to err on the side of more rather than less sunlight exposure for the prevention of cardiovascular disease and all cause mortality. And I really point your listeners to Cameron Borg's recent podcast with Pelle Lindquist of that Southern Sweden cohort, and he there was data, I believe that even and I won't I'll be paraphrasing here, but they even were finding, and they didn't publish this because um, they didn't want to promote this message that even those situations where there was sunburning, um, there was still mortality benefit. In
Mm.
terms of if we have to err on the side of more rather than less, it's probably it's undoubtedly still better to err on the side of more, just based on what this is, how important this is for your health, and that is it's not something I advocate for, I'm working hard to popularize a concept known as skin type latitude mismatch to help educate people on this reality of matching their UV exposure to their conditions and their ancestry. But yeah, that we've gone so far towards sun avoidance that I think
Right.
the narrative that say Dr. Cruz is
Right.
and is promoting, like we need to bring things closer to a more reasonable middle ground.
Yeah, because I mean, I actually just heard. I mean, I still think there's a strong section of the dermatology, you know, world who still believes that melanoma comes from a prior, burn event, like when you were 18 or 19 years old. And I still think that's a common, you know, refrain that's that's still used out there. And whether that's fact or fiction, I'm not sure. I mean,
Yeah, it's look, it's a really it's a very it's a nuanced and complex topic that and it's one that I have been I've actually been thinking more and more about. And I was actually I sat in with a dermatologist recently here in Queensland, and to really understand as much as possible what is was going on. I don't think that we can argue that the the ultraviolet light and its mutagenic effect on DNA is obviously playing a role in the development of skin malignancy. I mean, undoubtedly. The question, however, is what are the effect modifiers that mean a person with that amount of sun exposure develops skin cancers, non-melanoma and melanoma, versus someone who doesn't? Because you can have you can have two people of Northern European ancestry here in Queensland, Australia. They can have the exact same sun exposures of burning throughout childhood,
mhm,
baking throughout their professional career as a gardener or a roofer. One one is in and out of the dermatologist's office every 6 weeks,
right.
getting
Something
solar
cut off.
keratoses burnt off with cryotherapy and getting BCCs excised off um, every part of their face and body. And yet you have someone else who doesn't
At
who
all.
doesn't develop that at all. So the key point is that there's something going on that predisposes people to developing malignancy. The people that I saw that day in the office, none of them were optimally healthy by our standards.
Mhm.
They all had raised waist circumference. I imagine that they would not have a optimally dialed circadian rhythm. They could have been vitamin D deficient. They possibly could be likely having an ancestrally inappropriate omega 3 to 6 ratio based on dietary consumption of seed oil, linoleic acid, which is ubiquitous in the food supply. So my point is that to develop any malignancy, skin malignancy included, is that you have to have some degree of broken autophagy and apoptosis and cellular cleanup.
Right.
We know that vitamin D has a anti-proliferative effect on keratinocytes and skin cells. We that's what we know. That's what the data shows. We know, and that's exactly what the other metabolites are having. So, and what is likely in my hypothesis at this stage is that that cumulative lifetime of sun exposure kind of loads the gun for the developing of skin malignancy, but everything else that they're doing is really the difference between someone needing to get all these skin cancers cut off versus someone that doesn't end up developing any. But having said that, I still believe that the fact if you transplant someone who evolved in such low V light conditions, of Northern Europe, and you plonk them in Australia, even if you do live a optimal environment, but you expose them to a whole bunch of UV light, in some people it's just going to be inevitable that they develop skin cancers. So the melanoma story, well, topic that's like even more discussion and nuanced.
Yeah, it's that's a hard one because it's the scary one that nobody, they hear about, So it's like, I think some caution for sure needs to be, at least understand that we're still learning it. But it is the Swedish study and the British study. I mean, they're fairly, you know, they pretty much kind of throw everything that we've learned to it should open our eyes to say that there's something else here, right?
Yes. And look, and I think the way that I try and communicate this is balance scales.
Hmm.
So if you think about a balance beam, which is how they used to weigh food back in the day before electronic scales, is let's look at the risk versus benefits of sun exposure and sun avoidance based on its risk and benefits. And this is framing sunlight as medicine. This is framing light as medicine, and every decision in medicine is a trade-off of risks and benefits, whether it's a pharmaceutical intervention, a surgery, or light, which is what I and others argue is medicine. And so on one side, and this is not, and I'm specifically speaking to Northern European people who are latitude mismatched, and they're in an area of more light than they evolved. But you're potentially increasing the risk of skin cancer and photo aging of the skin, but that's from deliberate sun exposure. But what are you trading that up against? Reduced all-cause mortality, reduced cardiovascular mortality, reduced breast, colon, bowel cancer mortality, and reduced skin cancer mortality. And again, that was a finding that was in
Right.
both the MISS cohort and the UK Biobank cohort. Was yes, you might develop, you're more likely to develop melanoma or skin cancer, but you're 8 times less likely to die of it.
Hmm. That's interesting. And I mean, I think a lot of that's tied to the full spectrum sunlight. And I mean, I think, there's probably a lot of some nuance there. Does somebody just going out I mean, because, do you just go out at noontime and, roll out of the office and go sit out in the sun? Or are you getting in the morning light? Because the red light and the near infrared, precondition the skin, so to speak, or at least we believe it does, right? We definitely need more information about that, right? That's the whole
But
idea behind it.
it does. It does. That's what the LED, like this photobiomodulation data showing that's exactly what's happening.
Mhm. Okay.
Yeah.
So yeah. So the idea that the skin is preconditioned for the UV light in the early morning, and then you get your exposure to the UV light during the day, and then that is a mild hormetic effect, or if you get a burn and stay there too long, you stay in the evening sun, which is the red and purple, that actually helps to let's talk about helps to photobiomodulate the skin, right?
Yeah. And look, that's a thought that I've been having recently, which is the field of photobiomodulation is providing an amazing solution or workaround to this problem of skin type latitude mismatch. Meaning that if your parents are Irish and you live in Hawaii or you live in Mexico, El Salvador, Australia, Queensland, and you're getting massive amounts of UV light, more so than what your skin type was expecting, then you can use red light. You can use these supplemental longer wavelengths to both precondition and treat the skin after UV exposure to help promote healing and to reduce the likelihood of developing photo aging. I think that's a really powerful option that no one's talking about that people could really deploy.
Yeah, I mean, obviously, the best way to do it is to, if you go on a beach vacation, just make sure you see the sunrise, then make sure you see the sunset. And that's the best photobiomodulation there is in my mind. I mean, obviously,
Exactly.
it's it's easy. It's, as a dentist, I use photobiomodulation for wound healing and wound repair, and it's easy to get a 1040 nanometer laser and actually do it. But really, the sun is actually far better because it has all the wavelengths
Yeah.
in my mind, right?
Yeah. 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 And yeah, it is optimal from a light exposure point of view. But recognizing that not, and we talked about earlier that not everyone can be outside,
Mhm.
recognizing that we can use these other supplemental forms in strategic ways and for benefit. I think that's something that needs to be recognized. But
Yeah,
yes, educating people on the appropriate sun exposure technique that no one really is abreast of, it should be the starting point. And you talk to experts, you talk to Scott Zimmerman, you hear Dr. Andres Slemensky, who is a world expert on melanin, and they're kind of, everyone's really saying the same thing, which is obviously Dr. Cruz himself, which is if go into the shade rather than using chemical sunscreens or other forms of sunscreens that manipulate the spectrum of light as it's hitting your skin in a way that is different to what the body is expecting, and therefore disarming or messing with those natural homeostatic processes. Rather than use the sunscreen, simply go in the shade when you've had enough. And what I talk to people about when I educate them in my solar callus course and my private group is that you really have to use the early part of the day, use the later part of the day. If you're a Fitzpatrick 1 or 2
Hmm.
in an area of high UV yield, because if you compare yourself to the local population who are natively of that area, and you have a whole lot less melanin than them, that illustrates to you that this disconnect that we need to bridge with things like sun avoidance and with, like I mentioned, potentially even tools like photobiomodulation.
Yeah, so I mean, photobio it's the whole field is fascinating, and everybody's just kind of like, well, not everybody, but I mean, I know lots of people who are actually, digging into it and like they want to know specific protocols for photobiomodulation and things like that. And I mean, how do you use it in your practice?
Yeah, so I what I'm doing now is going to be a little bit different to how I would use it ideally, just based on what I'm doing at the moment. And but I think there's the strongest evidence at this point is for use in soft tissue, musculoskeletal soft tissue issues, wound healing, obviously skin repair and beauty and aesthetics. So yeah, the evidence is there. And then an area that I'm really excited to be exploring soon more is transcranial photobiomodulation.
Mm,
So the use of this light for patients with Parkinson's disease
mm.
and particularly, but also Alzheimer's dementia, and seeing reductions in their motor and non-motor symptoms with the use of this light. So I'm very excited and optimistic about what it is, and really as a drug, potentially even a drug replacement.
Mm.
If people can get benefits of the use of this light without the side effects of whatever drug they're possibly taking, then it might have the potential to be not only an adjunctive therapy but also a replacement. So
Wow.
watch this space, but the work out of there's a group down here in Tasmania in Australia and who are uh they've designed a very interesting looking uh head helmet. Well, it's not a helmet anymore, it's like a headpiece that also has a nasal piece.
Mm.
And the case series, I guess, the anecdotal stories that they're hearing out of patients with Parkinson's disease that implement this are remarkable in terms
Wow.
of improving. Uh, it's said that the most troubling symptoms of Parkinson's is not even the tremor or the mobility issues, but actually the apathy, the anhedonia, the depression, the sleep
Hmm.
disturbance that occur. And people finding extreme benefit in using this photobiomodulation to basically regain their life and reduce the progression of this condition, which, as we know, to circle back to this idea of mitochondria and
Mm.
it's mitochondrial inefficiency or death in these particular group of neurons in the substantia nigra of the basal ganglia. But to see that how much benefit that's had, and there's even stories of people regaining their smell. Like loss of smell is one of these characteristic symptoms that occurs in Parkinson's, and people regaining their sense of smell by using photobiomodulation. That's huge. So yeah, we need more research. Well, we don't actually need that much more research. We need more implementation, really.
Mm.
I think there's sufficient research, but for various reasons, no doubt related to drug company economic incentives, that this kind of thing is going to be probably not funded or promoted as much as it deserves.
Right, because how much would a, red light on the scalp cost or the sun, right? I mean, that's pretty much, the sun, you could actually make an argument that the sun will, go through the skull, right? I mean, the infrared and near infrared light, right?
Yeah, and look, people, Parkinson's disease patients have told me that they feel their symptoms improve when they watch the sunrise and
Mm.
really get in that early morning light, kind of grounded. And I think there's clear benefits of full spectrum, especially UV light for Parkinson's to help promote, resynthesize some of this neuromelanin.
Mm.
But with that late stage pathology, we're really talking about a different subset of people compared to
Yeah,
health optimization. And
agree.
really, we're going to supplement as much as we need to, and we're going to use as much supplemental red light as we can to improve symptoms and to improve outcomes.
Because really the photobiomodulation is really just it's a, mitochondrial rev the engines up, so to speak, right?
Yeah, exactly. That's how I think about it. It's as I mentioned, Glenn Jeffrey is really kind of delineating how it's working, and water itself is probably the chromophore for a lot of the light, and it's just massively as well as the electron transport complexes, but it's just optimizing mitochondrial efficiency, and it's optimizing that whole process. And it just goes to show, why is health optimization and longevity, it's a field that gets flooded with people trying to sell supplements, and guys like Dr. Peter Attia saying, you can exercise your way to immortality, tongue in cheek. That's my
Yeah.
that's my tongue in cheek comment. But the
But,
reason why it's fundamentally related to light um is because we're running a bioenergetic game here. We're in a game of bioenergetic optimization of how do we prevent the decline of the mitochondrial colony over this finite period of 120 years, which is the maximum, human lifespan. How do we slow the loss of mitochondrial function? How do we make it as slow as possible? So therefore, preserve health span and reduce or compress morbidity into the smallest time piece
right.
of period of time before death. And that is about, it's bioenergetic, and it's optimizing the energy flow in the body, and it's therefore optimizing mitochondrial function. And the best way to do that is to plug the mitochondria into this massive external energy source, which is the sun.
Sun.
And harnessing its power in order to optimize that energetic process. That's how I think about it on the most basic level. And that, when you take that perspective, Pelly Lindquist's findings make total sense, which is the more sunlight you get, the longer you live.
Right. And the
Which
shortest time period is that you're going to die. I mean, that's really it's like, I mean, we don't want to die, but we want to die quickly when we do. It's like,
Yeah,
if I could live to be 100 years old and then die soon, that's okay.
yeah. I just need to plug my computer in,
Yeah.
so I'm gonna lose video. Hang on.
Or
Um, so the Guy Foundation, who I really recommend people check out, who are basically leading the charge on quantum biology, they released a report on space health. And the reason why they're interested in space health is obviously because more people, with Elon Musk's
hmm
uh, space technology improvements, we're thinking about potential colonization of Mars. And they did a report on this topic, which I highly recommend people read if you want a very, very well referenced explanation of a lot of the mitochondrial concepts that Dr. Cruz has talked about as they relate to quantum biology. And that can sometimes be a bit overwhelming for people, which is, Cruz says a lot, makes lots of references, makes a lot of claims. And, as I said, that they're almost always true, but it's difficult for people to find the primary literature to
right.
investigate them. But when you read this report, it's actually providing a lot of the written backup and reference for a lot of these concepts, like the effects of a lack of magnetic field on mitochondrial function, and how magnetism is affecting optimal mitochondrial function. But the reason why I brought that up in the first place is because they have an amazing definition of optimal health, which is again relevant to this conversation. I'll just quickly read it out.
Hmm.
And one simple definition they write is that optimal health is a phenotype that maximizes health span and fitness while demonstrating morbidity compression or disease compression in relation to its species' maximum lifespan. In effect, the organism is healthy for most of its life, remaining fit, functional, and robust, with little evidence of disease for its age until very close to its time of death.
Hmm. That,
So
that's good.
I think, yeah, it basically sums up what both you and I are interested
Right.
in terms of this game. And like I said, sunlight is a part of that, and it's the natural terrestrial electromagnetic radiation that we've evolved with over 3.4 billion years.
Yeah, because I mean, I think when you think about the friends or family members that I have, or the people that you hear about, they get to 70 years old and they retire, and then they're dead within a couple of years, right? So that's a short, compressed whatever. But some of those people will get cancer at 70 and then live another 15 years or 10 years with cancer treatments for 10 years. How many times have we seen that? Or diabetes at 50 and then they live at 30 years with diabetes with all the maybe not 30 years, but they might get 15 or 20, but they have all of the sequela from that 20 years of diabetes, right?
Yeah, yeah, and look, let's to to put on the hat of this cynical hat, which we haven't up till now. It's been very science based,
Yeah.
but uh, this current medical paradigm, its business is normalization of that process that you just described. It's normalization that we all get sick
Hmm.
and rot away slowly in a nursing home, accumulating medication prescriptions and specialist physicians. Like, do you know what I mean?
Hmm.
Like
Yeah, sure.
that is exactly what we're kind of dealing with. Yet, what it's the opposite of what historically was the case, which was that when people lived in a species appropriate environment, then they do exhibit exactly what that Guide Foundation talks about in their report, which is this idea of living close to your maximum lifespan with fitness throughout the life and a very short period of sickness just before you die.
Hmm. Yeah. I mean, I think most people would realize that that's not what's happening right now, right? And I think as we've moved indoors and into our devices and everything else, I think it's changed, right?
Yeah, yeah. Look, and that's the modern environment and the modern environment that we're living in, and as it really relates to this conversation, I think that the biggest reason why that's occurring that very few people are talking about is the fact that we are removed from the environmental electromagnetic environment that we evolved in and that we are accustomed to evolutionarily. And if you the purpose of that Guy Foundation report on quantum biology and space health is basically coming to the same conclusion, which is when you put a human being beyond the protection of the Earth's magnetosphere, and you get exposed to the full brunt of the sun's electromagnetic emission without and it becomes essentially a non-native EMF, so to speak.
Right.
So mitochondrial dysfunction is the hallmark of spaceflight, and it's occurring for all these number of reasons, including disrupted circadian rhythms, inadequate near-infrared light, but also all this essential non-native EMF from the sun. How that's relevant, and I think that the corollary here is uh, one, humans should never have no business being in space because you are never going to get optimal health in such a profoundly uh, alien electromagnetic environment. But two is that where on Earth are we replicating what the astronauts are experiencing?
Mm.
And I would argue, and I'm sure Dr. Cruz would agree with me, is that we're doing that today in our schools, in our kindergartens, in our workplaces by living under fluorescent bulbs that emit 10% of the natural solar spectrum, with disrupted circadian rhythms, with light at night, deficient in near infrared, next to the Wi-Fi router, next to the 5G tower down the road, next to, I don't know, the electric substation, next to the radio frequency emitting the radio antenna. Like, we are simulating the same process. And what these researchers have found about the health effects of astronauts and mitochondrial dysfunction, we is happening on planet Earth by existing in this completely removed electromagnetic environment that's sunlight deprived and non-native EMF filled.
Yeah, I think the non-native EMF thing is that's a hard one for most people to wrap their heads around, and it's the hardest one to mitigate, especially living in the cities and living, a modern life. I mean, I mean, who doesn't will have their phone in their pocket, right? I mean, and these are all things that are very difficult to, it's hard to go backwards once we're already here, right?
Yeah, yeah, it is. It is difficult, but it's the purpose again is education, and therefore permitting more informed choices. If more parents knew that giving their toddler an iPad that is emitting this EMF as well as all this blue light
Mm.
was a bad idea, then companies like Daylight would get funded quicker, and we would get more human friendly technology quicker. So it's yes, we can't do a lot about it now, but the more educated and empowered people are, the quicker we can find a human friendly technology so that we can all move forward in a way that doesn't allow it to kill us. Because humans are I mean, we're incredibly intelligent and adaptable, and I think if there's enough intellectual horsepower thrown at these problems of how to make technology human friendly, then we would find solutions. But as it stands, there's a whole bunch of interests. And if you're interested in maybe listen to Dr. Jack Cruise's recent podcasts on various topics related to
Right. The
the
pol
industries.
Yeah, the
And
industries and where we're at, right? Yeah.
yeah, but the Danny Jones podcast. But really, um yeah, we just need to be educated about it more. And that's a slow, but it's a consistent process, because people want to be healthy.
Hmm.
People going to get to an inflection point where chronic disease is so burdensome on an individual, community, societal
Right.
level that where that things are going to get turned around. And I really coming full circle, we're seeing that's occurring with the Make America Healthy Again movement,
Mm.
and
Right.
JFK and RFK
Okay.
Jr.
Right.
and Cali Means, and these messages are starting to permeate through. Yes, they're predominated by
Right.
the food message, but the next question for any inquiring mind is, if metabolic syndrome and chronic disease is a mitochondrial problem, how else do you fix mitochondria? And then you
Right.
start connecting the dots and realizing that the light, sunlight and circadian rhythms are a fundamental piece of the puzzle. And then we start getting some more movement. So, Doug, I think we're early,
Yeah, I
still
agree.
very early in this whole process, but I don't doubt that in another 2, 3, 5 years, people uh, with influence and audience will be learning and advocating and talking about the same topics that you and I are right now.
Yeah, I'm actually very encouraged by the whole, CGM movement and the access to care of those. I think it's a powerful tool, and I think it starts the process of understanding what processed food does. And so once people can start understanding what that does and they can get a little bit of momentum going, they can then, I think it's easier for them to actually start embracing circadian biology ideas, because all of these things they're working on with food can actually all be mitigated by the sun, as you eloquently, described like an hour ago or so, right? I mean, at the, cholesterol, obesity, triglycerides, glucose, they're all modulated by the sun, right?
Exactly. And try telling that to an endocrinologist, but
Right.
that's the reality. That's what the data shows. It's not our opinion. This is what what the scientific and biomedical literature says. So, and that's, look, that's why my effort has been lately around sunlight narratives, because the biggest barrier to getting people out into the sun is this disproportionate idea of the harm versus risk
Hmm.
that equation. So
Right.
people people need more education to understand that sunlight avoidance is a risk factor for death, on par
Right.
with smoking. And they need education about that. And it's hard when narratives around melanoma are, being pushed by certain organizations, are really advocating for blanket avoidance or
Right.
severe reduction in that in no way understands how the mechanisms that we've described, and really they don't have appreciation because it's beyond the scope of their narrow kind of blinkered specialty. Not that I believe that anyone's trying to do the wrong thing by their
Right.
patients, but their misguided confidence in their own approach seems to be robbing cardiology of its most important primary prevention tool, which is
Right.
sunlight. And what is responsible for the most years of potential life loss? It's ischemic heart disease.
Hmm.
And obviously, and neurodegeneration is there, but in terms of years of potential life loss, it's heart disease because it affects younger people. So, preventing, having this idea of scale of the problem is so important, and proportionality of the competing risks of skin cancer diagnosis versus having a heart attack. Like that they're such in such magnitude different. Again, I'll reference Pelly's podcast with Cameron, but he
Right.
talked about it was a physician. I don't know if it was an African American dermatologist or African American physician, colleague of Dr. Lindquist, but he ran the numbers on the all cause mortality trade-offs of skin cancer versus heart disease for him as an African American living in a low UV environment in the US. And I don't know what analysis he did, but he exactly it was, but he concluded that there was a 5,000 fold difference in his risks of getting skin cancer versus having a heart attack, and basically used that analysis to inform his use of a sunbed, as as a dark African origin person living high latitude. So it's not, that formulation is going to be slightly different for everyone, but even if you are the palest skin type, your risk of death is higher from stroke and cardiovascular disease than it is from skin cancer mortality. And in Australia, we have a graph like our Bureau of Statistics puts together, and years of potential life loss. And as I mentioned, I think it's about 80,000 or something was ischemic heart disease, and skin cancers, including melanoma, was 1,500 or lower. So that's just one idea of the magnitude of difference of the problem, and then how much we can modulate that number of ischemic heart disease and reduce that risk. I think I explained earlier in the episode that we can really attack almost every risk factor except for smoking.
Hmm.
Um, and physical activity with sunlight. So that's how important light is for this cardiovascular disease story. And look, if people are really interested, then I did a whole talk on this topic called, um, maybe somewhat arrogantly, what your
Yeah.
cardiologist doesn't know about sunlight and heart health. But I did that. I deliberately used that title because, as I mentioned before, I believe, and I think the data suggests that sunlight is the most powerful tool for primary and secondary prevention of ischemic heart disease. That no cardiologist, except for I think Dr. Jack Wolfson in California has talked about this for a while. But there's no one else who's giving their patient the critical information they need to prevent um, heart disease. And Stephen Hussey is doing a great job. He's a chiropractic doctor, talking about structured water
Mhm.
and fourth phase water as it relates to heart disease. But even those kind of stalwarts or these proponents of the metabolic medicine and approach to heart disease, like Dave Feldman, Nick Norowitz, they're still on a biochemical lipid based paradigm, and that needs to change if we are to inform our patients of best practice to do with prevention of this killer in society.
Yeah, I don't think food is enough for sure. I definitely don't. I think food is a gateway, but I think unless you start to figure out and learn how the light can help you, I don't think it's enough, and I don't think it's enough for our patients either at this point.
No, it's an incomplete story, and that is something that has really forced me down this rabbit hole and let me and forced me to take all the bait that Dr. Cruz kind of let out. Is that
Yeah,
I don't feel comfortable enough telling someone, eat a low carb diet and,
right,
that and don't worry again about your calcium score, whatever it was. So, and we need to understand the problem as completely as possible so that we can give the best advice possible to our patients. So that's what drives me. That's
right,
what keeps me to keep learning, because I never want to be in a position where I've, given someone the wrong or incomplete
right.
advice
Yep.
about best practice. And the history of medicine is replete um with instances, particularly regarding drug therapies, but not only, of, this is how it's done, this is what you have to do, and that ignorance is or that arrogance is often accompanied by iatrogenic harm when
Mhm.
people, either by omission or commission. So
That's how I feel.
that's mm,
I don't treat sleep apnea per se, but I can recommend skeletal changes and with the hopefully side benefit that it'll improve sleep and airway and all of those things. And I mean, I can't recommend it unless somebody is gonna embrace the whole enchilada now. I mean, that's pretty much where I'm at, It's like unless you're gonna start to understand that there's metabolic factors here and there's circadian factors at play, then I don't know if you should, it's a different informed consent discussion before I send somebody to go get those things done for me personally now.
yeah, yeah. No, yeah, it's burdensome, and it's always as much easier to simply just follow the
Hmm.
standard line when it comes to advising our patients. But really, when there's such asymmetry of knowledge, there's responsibility.
Hmm.
What's the Spider-Man movie? With great power comes great responsibility.
Yeah,
So
right.
there is great responsibility to inform people of what we think is the state of the art. Um, yeah, based on optimal prevention. So
And
yeah, that's
I don't even think I know it. I don't think I mean, I think I still have lots to learn for sure. So, I
uh,
mean, I think, so what are you learning next? What rabbit holes are you going down now?
yeah. So like I said, I'm really at the moment hammering the skin cancer rabbit hole, and especially from a clinical point of view, to really, and I'm looking to get on a very experienced dermatologist who's been on the forefront of skin cancer diagnosis and treatment here in Queensland, to to really hone in and to help, again, and I'll mirror your comment about not knowing everything. Of course, this is very far from, and I mean, never gonna know everything, but the process is ongoing. But yeah, to get a better idea about skin cancer and those types of things, and then probably my focus after that will be on cardiovascular disease again, because it's it's the it's a major killer, and there's just seems to be a profound lack of movement from the cardiologists about optimal prevention, and like we talked about, that I think they're mired in the wrong intellectual paradigm, which is a relic. It's a relic of Ansel Keys in the 1950s. They're still talking about lipidology. They're still talking um about cholesterol, when atherosclerotic cardiovascular is a clotting disorder. It's a problem of blood clotting and blood flow dynamics,
Right.
and you fundamentally, that you need to optimize the light, the water, and the magnetism to optimize blood flow and reduce clotting. Um,
Right.
so that's probably after the skin cancer stuff. That's probably what I'll be, focusing on next.
That's interesting. Well, we've
Mm.
been going almost for a couple of hours here, so I don't want to waste any more time. It's been a great discussion so far. I've enjoyed it. I mean, we should do it again sometime because I think hear where you're at next. But I really appreciate your time and let me know just I'll put all your shows in the show notes, and I'll put even some of the shows that you referenced in the show notes too. But how do people find you?
Yeah, it's been a great discussion, Doug. Thanks for bringing me on.
Yep.
My people can find me, like most of my work is published on my YouTube. So Max Gulhane MD, and I'm active, but probably my most active platform is my school, my private group. So if you want to talk to me or interact with me, ask me your questions, then join my private school group, because that's where I'll post links to interesting studies. I'll post interesting videos that I'm watching.
Mm-hmm.
That doesn't percolate out into the Twitter. I don't have
Right.
enough time to maintain all those platforms, so I
Right.
really reserve that for my private members. So if you're interested and you want to kind of get a closer idea of what I'm like thinking about, then join my private community on school. But otherwise, my website, drmaxgulhane.com. And I'm also on Instagram, which I kind of occasionally post some
Once in a
some
while,
things.
some new
Yeah.
things. Yeah.
So that's where you can find me. And
Of course, your
if anyone,
podcast, the Regenerative Health Podcast on
oh,
YouTube,
sorry,
and on
sorry.
all of the right.
Yeah, Regenerative Health podcasts on YouTube and on the podcast platforms is where I interview guests and release, some talks that I've done. So yeah.
Okay.
But yeah, if anyone's in Australia and wants to, I'm actually doing a retreat. We've got like a handful of tickets left, maybe three left
Mm.
in Byron Bay hinterland at the end of November. I don't know if anyone in your audience is from that area, but or in Australia. But if you want me to kind of meet me and I'll walk you through my interpretation of circadian biology and rhythms, then in a pretty luxury setting, it's going to be a great time. We're gonna have some private chefs coming in. It's going to be a great time. But yeah, that's kind of what I'm up to. And yeah, thanks for having me on, Doug. It's been a pleasure. And yeah,
Yeah.
happy to talk again in a couple months, I guess. Yeah,
Yeah, for sure. Sounds good. Thanks, Max. I really appreciate it.
cool, mate.
Cool.
Thank you.